So, well, as I was saying, this is a disease of old brain. Uh, so, basically, if you have MRI section, a coronal MRI section, if you draw a line from cingulate sulcus to circular sulcus to collateral sulcus, everything inside is old brain and everything outside is new brain. New brain which is neopallium, which we all have. So this is the evolution of brain over last 100 billion years. This is a newly diagnosed disease. It is not a new disease, newly diagnosed disease over last decade or so. Well, so basically autoimmune limbic encephalitis was first reported in 1968 and it was in association with a cancer, lung carcinoma. So only until 2001, it was thought that limbic encephalitis is almost exclusively in association with the underlying malignancy. Till you had in 2001 a VGKC antibody-mediated encephalitis was discovered because again this was in parallel to advancement in neurochemistry. And 4 years later, NMDA receptor encephalitis was discovered. So the whole idea of telling you this, limbic encephalitis, as the word indicates, limbic system is old brain which consists of mesial temporal lobe, hippocampus, parahippocampal gyri, part of thalami. So this is a system of the brain which is responsible for personality, memory, and so sometimes and emotions. So the usual presentation is psychiatric, not neurological, unlike encephalitis, and that is why this was a famous movie. I was reminded by Dr. Shuchi when she invited me for this talk. I saw this later on, Brain on Fire. So that was a Hollywood movie. It was account of patient herself, Susanna. We described. I'll tell you. Gradually as I discuss further. So let's be first of all very clear. You have a syndrome which is limbic encephalitis. Somewhere in limbic system there is affection. So presentation is going to be some kind of behavior problem, psychosis, depression, agitation, or it could be memory related problem, forgetfulness. So these could be the common features. So you have limbic encephalitis as a syndrome. Then you have antibodies. Nowadays, as the time is passing, we are having more and more antibodies. So common are Caspr, LG1, NMD receptor, and there is cause. It could be only two. Either it is paraneoplastic or it is autoimmune. So these are the only two causes. Well, if you see here, this is, you may take simple presentation. It's a cell, you have a membrane, you have a nucleus. Okay, everything, every antigen inside, every protein inside nucleus are intranuclear antigens against which antibodies are formed. And another group is you have surface antigens. So here you have MAR2, ANNA1, ANNA2, and on the surface you have this LG1 antigen, Caspr. Then on the synapse, again on the surface you have NMD receptor, you have AMPA and GABA receptors. So basically, the whole idea of telling you this, if you have surface antigens, these are probably immune mediated limbic encephalitis. If you have intranuclear antigen, then these are paraneoplastic. Okay. So common is like, you remember four today, LG1, Caspr, NMDA, and GABA receptor. So these four constitute 90% of autoimmune encephalitis. Rest all you can forget. So, and everything which is inside nucleus, if you have antibody, these are usually paraneoplastic. As I said, for an autoimmune encephalitis, one has to be immunocompetent, so one can mount the immune response. Why? Like in encephalitis is inflammation in brain. So you have to have fever, seizure, headache. In autoimmune encephalitis, they do not present early in the disease. They would just present with some subtle manifestations. So this is the difference in clinical presentation. Before we were, having these antibody assays, we were actually picking up based on. So most important thing is that if you short onset, let's say 3 months history of forgetfulness, behavioral problems, then you have high degree of suspicion of this being a autoimmune encephalitis. Second, as I said, subacute onset. Second is you have some new CNS findings. Either of these new CNS finding, MRI or CSF suggestive of autoimmune encephalitis, and you have excluded other causes of encephalitis. So let's start with unit 1. She was an elderly female with fluctuating sensorium, occasionally identifying family members, recently incontinent from last 2 weeks. She was investigated thoroughly. She had normal blood investigation except for IgM typhoid was positive, some traces of pus cell in the urine, and low sodium. So obviously in India, typhoid is so common, so she was able to enter encephalopathy with probably UTI, and she was treated for the same, and she kept on deteriorating. Then another, unit 2, another patient. She is a young female with recent onset behavioral problems. She had some forgetfulness with some episodic aggression. She had some conflict with friend. So probably she was labeled as having anxiety neurosis. She underwent multiple psychiatric consultation, hypnotherapy sessions, and she had normal hemogram, MRI, and CSF. So what makes me suspicious, because these two index cases I showed, what makes me suspicious is short history, neuropsychiatric abnormalities, memory disturbances, cognitive impairment, and later on they have seizure, movement disorder, autism and sensorium and dysautonomia. So by the time those features appear, it's very late to treat them because this is a treatable cause. The whole idea is immunotherapy is, responsible in 90% of the patients. And if you deny them, they end up in psychiatric wards labeled as schizophrenia or anxiety neurosis and missed, more often. Well, now we have antibody testing. So again, credit goes to advancement in chemistry, in biochemistry, neurochemistry. That we have various antibodies. So we have these commercially available antibodies. We are going to be, investigating them. You would know it better than me. Cell-based assays are better than immunoblot. But for all intracellular antigen which I was mentioning, you have best test as of now in India immunoblot. While for surface antigens, you do cell-based assays. Okay, so this is how this would appear with immunofluorescence assay. Most of the time these are negative. So most common is negative. Then you have MD receptor, anti-Caspar, anti-IgG1, as I said, and GABA. So these four, you remember, if you can diagnose these four antibodies, your job is done for more than 90% of the patients. Okay, so antibody titer interpretation. Only my message here is, we should be ideally doing both CSF and serum together. Paired assay is much better than doing it in isolation. Obviously, CSF has more titer of antibody compared to serum. But the paired assay is better than doing it alone. So always ask the medicine resident that send both samples together because yield is more and you can actually, it's worth putting money, though it adds to some cost, but it's worth putting money because these are the diseases where you have fantastic treatment response with immunotherapy. Okay. So as I said, let me repeat for the sake of repetition here, you have first group with classic paraneoplastic intranuclear antibodies. The reason here is, here the antibody is not causing pathogenicity. That it is antibody is mediating cytotoxic T cell injury to neurons, and that's almost irreversible injury. So the prognosis is very poor and they do not respond to immunotherapy. Why? When you have surface antigen and there are antibodies to that, it is antibody mediated pathogenicity, so receptor number can go down, but we do not have irreversible neuronal injury. And most of these patients respond, as I said, 90% they do respond to treatment. They have to be treated early in the course of disease, let's say in first couple of months. And most of the time it is highly underdiagnosed disease because they are not picked up in first 2 months. As I said, they are mostly treated by psychiatrists or psychologists. Well, so here again it is same thing, intranuclear and surface antigens. So mostly these are old people. As I said, you remember 4 of them and your job is done. And recovery is to the tune of 80%. This is something you have negative antibody, you still have high degree of suspicion, you do not find any malignancy underlying. So this was since cell-free plasma DNA, as me and Anjul was there with me and we did this cell-free plasma DNA as an acute biomarker for stroke. We do not have any biomarker for stroke. That's so unfortunate. You have PROC-T, ACP can be for heart, but not for stroke. And really for prognostic optimization of therapy, you really need to have a biomarker. It is not for diagnosis, it is for prognosis in the very beginning. Within the first 24 hours, you have to have a biomarker that can suggest you how you are going to treat, how you are going to open up the vessels if it is acute stroke. So well, the whole idea is cell-free plasma DNA. Once DNA is inside cell, it is released. So here also we did, cell-free plasma DNA gives you a prognosis for autoimmune encephalitis as well. If it is more than 10,000, invariably, probably they would be discovered to have malignancy, let's say 1 year or 2 years down the line, and they do not respond well to treatment. So that was just one of the publication we did. MRI, as I said, antibodies, the definite answer, others are suggestive. MRI sometimes is very suggestive. Some of the MRIs are very suggestive. Like I said, this is limbic encephalitis. So this is limbic brain. This is mesial temporal lobe. Okay. So this is limbic encephalitis LG1. If you have something on MRI, hypothalamus and thalamus involvement in a patient where you are suspecting autoimmune encephalitis, so this is very classical of MAR2 encephalitis, which is paraneoplastic. So you look for, in MAR2, you look for seminoma of testis, so do ultrasound. If you have something like this, bilateral striatal nuclear involvement, so this is CRMP mediated encephalitis. If you have linear, radially arranged, perpendicular to the atrial ventricle, these lesions, you have practically GFAP encephalitis. So these certain MRIs are so classical that you really don't need to have antibody testing even. But that's not the case all the time because, as I said, most of the time MRI will be normal or it will show some involvement of limbic system. This again I said hypothalamus, thalamus involvement, classical MAR2 encephalitis, seminoma of testis is usually associated with this. Well, so autoimmune encephalitis, since it is underdiagnosed, you should have high degree of suspicion. Again, I am repeating, any neuropsychiatric manifestation with forgetfulness, with or without emotional problems for a short history for let's say 1 or 2 months, go for them because they will not present like meningoencephalitis. But at the same time, you have to do your CSF, rule out infections. Because if you have treated with immunotherapy in a tubercular meningitis case, it's a catastrophe. So you rule out all these. This is again standard CSF analysis with 14, viruses and bacteria and fungi all put together. It's again a commercial test you do in CSF in all patients. Biofile with a gene expert. So I have this. So this is how you would rule out infections. Well, again in this autoimmune encephalitis, we tried to look for any microbiota signature because again it was part of our DST project. We did CSF, but we did not find any microbiota signature on new generation sequencing in any of these patients. You have to invariably look for cancer in these patients at least for 2 years. So you do a simple ultrasound. If it is negative, do a CT scan. And still, if you have a high degree of suspicion, then you do a PET study. This is the most common encephalitis. Usually it is in the younger females. They present with neuropsychiatric manifestation. They present in children also, less than 20 years. Then seizure is usual manifestation. But in elderly, more than 12 years, it is mostly forgetfulness, behavioral problems, and all those things. So as I said, these are reversible. So the pathogenesis here, you have antibody. This is capping NMDA receptor, cross-linking, and finally it is internalizing receptor. So as I said, if patient is not admitted in ICU, if it is picked up early, the immune response, treatment response is very good to immunotherapy. There is risk of variable relapse risk, so you maintain immunotherapy for next couple of years. You treat them with first line. So basically, treatment immunotherapy, I mean, in acute stage, you use methylprednisolone for 5 days, intravenous immunoglobulin. You don't wait. If the patient is not improving, then add IVIG also. Don't wait for 1 month to see the response. Add them fast, treat them aggressively. And then you have second line immunotherapy. Nowadays you have rituximab, you have cyclophosphamide. So you have given rituximab, you are sure you have depleted B cell for at least 6 months. This is classical EEG of NMDA receptor encephalitis. Delta brush is usually present in preterm infants, but in NMDA receptor encephalitis, you have delta wave, that's slow wave, and superimposed on delta wave, you see this fast activity, which is in beta range, 20 to 30 hertz. So this extreme delta brush sign is almost always, very typical of NMDA receptor encephalitis. I mean, we will not go, but this is present mostly in frontal area. It is synchronous, symmetric. Only rarely you require a PET study. So I just come back and finish with two cases we discussed. First was that young female with episodic forgetfulness, some behavioral problems, fighting with colleagues, conflict with boyfriend. So finally, MRI, everything was normal. MRI, EEG, CSF was normal, but 4 years down the line, she developed some involvement in limbic system. But she was treated with immunotherapy and she responded very well. So the whole idea is anxiety, neurosis, schizophrenia. So you first have to rule out this is a short history. Then this is something called VGKC complex antibody. You have, I said, LG1, Casper2. So again, all are limbic encephalitis. LG1, usually these are limbic encephalitis. The very typical thing, sometimes you miss it. LG1 encephalitis patient, बस इतना ही होता है. They will just head will go to one side. इतना ही होता है. That's all. And they are usually missed. So this is classical facio-brachiodystonic seizure or movement disorder. Even if it is not seizure, it is just per second. So it's not seizure even. So if you find this is pathognomonic of LG1 encephalitis. Okay. Then you have Casper2. Most of these patients with Casper2, the distinguishing clinical feature is they have neuromuscular problems. They have neuromyotonia, myoclemia, fasciculations. Okay. So that gives a high degree of suspicion to this being a Casper2 encephalitis. I come back to my unit 1. I told you elderly female, sometimes she was recognizing family members, sometimes she was not. Typhoid positive, UTI. But finally, she underwent this antibody testing because the clue here was a low sodium and she had occasional this facio-brachial dystonic movement disorders. So I'll skip these. GABA, last thing I would say, GABA receptor, because GABA is a major inhibiting hormone. So most of these will present with seizure. Sometimes they present with status epilepticus. Then there are other encephalitis which are not that common. Cell-based testing is one thing, you should remember that one should do cell-based testing in these patients. There are hardly few publications from the country. And this is the last slide. Interestingly, this is the latest antibody found. This is Eglon5. Eglon5 encephalitis, again a limbic encephalitis. They have classical sleep problem, some gait problem like TSP. Sometimes they have bulbar symptoms like dysphagia and all those things. But again, they are linked between autoimmune disease and neurodegenerative disease. In the beginning, I was hearing about Alzheimer and Parkinson and all these things. This is something unique disease where they have found, hyperphosphorylated tau accumulation. So that is degenerative brain disorders like Alzheimer and Parkinson. So this is a very important from research point of view also that this is a common link between neurodegenerative disorders and autoimmune disorders. So Eglon disease, Eglon5 is, I think this antibody testing we have from last 6 months or so. So take home message is high degree of suspicion and go for a paired antibody testing. So I think that's how one should be careful in diagnosis these very underdiagnosed diseases. Thank you very much.
Thank you so much for such an insightful presentation. We can take the questions, I think, in the tea break later. So I would like to request Dr.